order at 12:08. Thank you all for being here. I hope everybody, looks like the coffee pot is here and it's quite chilly, so I would suggest getting some. Stay warm. Are there any citizens wishing to address the committee? There's no one on the list. No one on the list. Thank you. How about approval of the minutes from our February 23rd meeting? Got a motion by Steve and a second by Dorothy. All in favor, say aye. Aye. Great. Quick chair report. I don't have much. I just want to thank you all and apologize for having to reschedule this meeting from the 27th. I'd also like to see, and I don't think we need a formal decision today, if we like the format of having the 3 meetings back to back. I think it's easier for legal counsel. It's certainly easier for us who have to be here for planning or another meeting, if we could maybe get these on the same day and same track. But just a suggestion. I know that we sit around here and think that we run this hospital, but really we don't. It's the nurses, and it is Nurses Week, so we wanted to, for all of our nurses out there who are part of the lifeblood of this hospital system, wanted to thank them and hope that they are having a very good and enjoyable Nurses Week. I can tell on Facebook it seems as though that they are, so that's good. We won't have a report from Michelle today, but she did promise me that we would have a lengthy report at the next meeting. So with that, we will go ahead and move on to reports and updates and our enterprise risk management update with Ron. Ms. Burnside, are you just today? Yep, there she is. Thank you.
Sharon, can you help Ron?
See, I told her that I would get this right.
Okay. Well, thank you all. This will be a little bit of an abbreviated governance meeting today. I know you're so disappointed, but we do have a couple of important things we wanted to share with the committee. I want to start with the ERM report, you know, as many of you know, over the past several months, we've been developing these 11 enterprise risks and from the risk assessment that we did last year. At the last governance committee meeting, Dr. Rosinia and Dr. Johnson presented clinical quality and physician engagement in terms of our risk profile and kind of how we see risk, how we frame this up as the beginning point of a discussion with the broader organization as to how this relates to their individual job responsibilities. So today, the third of the 11 that we're presenting in a risk profile is for patient experience, and so that's why we have Laura here with us. Laura has been a tremendous partner in helping to articulate this throughout various forums throughout JPS, including Leadership Connection, Robert's meeting, some of the nursing forums as well, and we've gotten some good feedback. And so this is the last forum at the board level doing this. But before I turn it over to Laura, I just want to give you a quick update on some other elements of the ERM program that we're doing. I think, as Robert pointed out last time, I had a shameless plug about the presentation that Frank and I did in DC around ERM and quality. I will say, I don't know if Frank is still here. It did go well. Frank's laughing because he was around a bunch of compliance and audit people, and so he said, for the first time, I feel cool around this group. But we got a lot of great feedback. There was probably about close to 100 people that attended our session, and we talked about the importance of governance and compliance interfacing with the quality program, and that's a hot topic in the risk management and compliance circles these days. And so there was a lot of great questions, and we talked about our journey that we're on here at JPS, and so it was a good forum, and I appreciate Frank again for partnering with me with that. The last point I would say is we're in the process, I've mentioned this in the prior governance committee meetings, is in order for the ERM program to really be sustainable, it has to have an established process. And it has to be something that's more than just me having documents and Excel spreadsheets and Word documents. And so we were able to partner with our IT colleagues and get the GRC module from ServiceNow, which is ServiceNow is already a platform that we're using from in IT, and they happen to have a governance, risk, and compliance module that we were able to get. And so we're in the process now in the beginning stages of putting all of what you see here in an automated form so that once we get past this initial stage of articulating what the risk profile is, how do we push this out to the broader JPS organization? How is this sustainable? How is this able to be updated in a real-time way? And so we're excited about that. It's going to be a lot of work for us on the front end, and so that's so not only myself, but Michelle and Irma and the whole team is working now through the implementation process. So that's all I had in terms of the prepared comments before we move on to patient experience. But is there any questions for me before we do that? Okay. All right. Well, we'll move on to the patient experience risk profile summary. And as you've seen before, this is the similar format. We have a definition of how we define patient experience, some of the key risk areas that we work with Laura and her group on, and then some of the things that we're doing. So, Laura.
Thank you so much. Good afternoon, everyone. Thank you for having me. It is a really neat thing to me that I'm the third one that Ron has brought to this committee, because between quality and physician engagement lies patient experience, right? So we actually, oh, sorry, am I not on?
It's great. There you go. Let's put a little closer.
It's on. Okay. Are we good?
Yes, but is there something to be said about the fact that you're the third one that Ron has brought?
Well, other than he saved the best for last is what I'm going with, right?
That's for next.
Just kidding. No. No, other than he probably wanted you to be off on a very good start, and so we can trail off. But as we know, our key risks are really trying to make sure that we consistently offer and provide a great patient experience for every single person and every guest that walks through our doors. And so being able to sustain that and hardwire it is tricky, frankly. And so we have embarked on a couple of things, and I want to touch on two of the elements that we have been working on when it comes to patient experience and enterprise risk management. So the first is actually some very exciting news that JPS has, and we were actually one of 7 hospitals that was selected nationally to participate in a pilot. And this is where that bleed over into physician engagement happens. And so this pilot is very exciting for us, and it's a physician project. And it really is about engaging with and for physicians rather than at and to them. So it's a different type of module and a different type of project that we've embarked on. And the design of it and the goal for us, our number one goal with this project, is to enhance physician well-being and decrease burnout. Because what we know is that when our physicians are more engaged and when they are highly energized about the work that they do, our patients' trust increases, their compliance levels increase, and we see things like better quality outcomes, we see length of stay decrease, and that sort of thing. And so we're very, very excited about this. So we went a couple of weeks ago to meet with the other hospitals that are also participating in this. And so it was really fun to sit down together and figure out how do we drive this at a national level. And being part of that initial on-the-ground team of people that's really working to drive this so that hopefully this becomes well, it should become a much more well-known project throughout the nation as we go on. A little bit of pressure, right? Like if we don't do a really good job with this, we may end up in a different position, but so far so good. So the goal of the project for us truly, and for it's called the Physician Effectiveness Project. And the goal of it is to really create an environment where physicians thrive. And so it's kind of an exciting thing. We're one of 7 hospitals, as I mentioned. There are about 20,000 physicians that are participating, some on their own, and then some as part of this project as well. And what they do is this center has actually created curriculum by physicians. So the physicians have created the curriculum that we drive, and they create it for physicians, and it's specifically designed for JPS. So we have the mechanism to go in and work with our docs on specifically designed criteria, modules, videos, learning platforms, et cetera, that physicians across the country have developed, and then also have a platform where they can ask questions, they can dive into things a little bit deeper, share best practices, et cetera. So it's pretty exciting as we go on. There's lots of opportunities for us to get some exposure to this. The project itself focuses on 4 areas. Quality and safety is one of them. As I mentioned, patient experience. You can't really have patient experience without good quality metrics too. So it flows over into that. Physician well-being, patient experience, of course, and then clinical leadership. So what we've done is we nominated the 15 physicians that are currently going through our TCU leadership program, and they are our champions for this effort. And then they've been asked to invite 5 friends along on this journey that will participate as ambassadors for us. So we'll have and then the 15 that are involved in the TCU project, as well as our chairs and medical directors, makes up about 23 champions, and then we'll have about 150 people that will start on this pilot together all at the same time. So our
Let me
yeah.
interrupt you real quick and let y'all know that, because we mentioned the program, but let me mention it again. The 15 doctors that we have in our physician leadership program has been a great cohort that we've established with TCU to help our doctors with a variety of issues, to openly discuss burnout, to openly discuss business practices, to openly discuss how the process works, and it's done through the Neely Business School. So they've got speakers that come in, they have an ongoing class, and we work with them really closely. Dr. Rosinia had established that program, and it is a very valuable program. And we asked those 15 doctors if they would help select the next 15 doctors. And they are overly aggressive at finding good doctors to be in the program. They take their homework, they do that. It's been a really valuable program, and that's given us great insight into some of the things that the doctors may need, but also a better understanding of how an institution of this size works. And you can't just put up your hand and say, this is what I want today, or how do you better communicate and keep those lines of communication open. So it's been valuable on every level.
Yeah. I would agree. Their engagement level is very, very high when it comes to this. They're excited. So tomorrow's actually our kickoff, where they'll get to see a little bit inside the project and really start to dive into it. The neat thing about this project is that it actually scores their participation, and so it's very competitive. So you can actually, when you log in, you see how many points you have compared to everyone else who's logged in there. And even for me, not a doctor, right? I'm going, how do I get to 65 points right now? You know, so depending on what all you do, you get different points. So it taps into that competitive nature as well as the high engagement level of those physicians. So Dr. Rosinia, Dr. Elliott, Diana Prachel are all participating in this with me, so that we're sure we're covering all bases.
Laura,
Yeah,
before you go further,
sure.
the program or the curriculum that's designed for the doctors, how was that developed?
Yeah. So there is a physician that is a practicing physician who also is kind of the guru in the patient experience space and has been for a long time. I've known him for a lot of years. He works at Sharp Healthcare, and he and Sharp Healthcare have ventured into this project together, and then they have partnered with our patient experience vendor. So there are about 4 or 5 physicians that are part of the Sharp Healthcare and Physician Effectiveness Project team, and they develop the curriculum based on what they're hearing in the space for physicians and patient experience. And so there are things like videos or articles or tools, different testing mechanisms and that sort of thing that group has developed. And then as they're out, one of the things that they've asked of us is that when we develop best practices, they would like to actually showcase JPS as a national leader in that particular practice.
And Pastor, to
So-
part of your question, the TCU program was developed by a program that they've had in place for area hospitals as well, and anybody else who wanted to take their courses. We sat down with them and customized that course to JPS. And we said, here's where we think some of our needs are. We got input from our doctors and what you want to learn, what do you want to know, what would help you if we offered this course. And so we developed a curriculum with the Neely Business School and some of our needs, and we sort of tailored that. So the two programs that you have is the overall program that we have at TCU, and then the patient experience that we are a pilot for the nation along with the other hospitals. So two programs that have some simultaneous
Correct.
sort of interactions and using the same physicians in both, because we have the highest level of engagement from them right now.
Okay, good. Because
that
the
help you?
reason I ask that is because we all know that there are consistent concerns or complaints that patients raise. I mean, the part, what the part, you still hear that same.
Sure.
And I'm just wondering, did we capture that? Is there some
Yes.
kind of way we put that in so that in the training?
Yes, that's a great point. So the first thing that we are tackling is the physician engagement component and enhancing physician well-being. Part of that is increasing empathy and compassion. And there's been studies done now that link empathy and compassion and the demonstration of that to engagement in your work. And so that's part of the very beginning curriculum that we will dive into. Yes, and then we will move into what we know is really most important to patients, which is communication, and there's an entire module set up on that, including the 125 studies that have been done linking communication to patient experience.
Mr. Worthy?
What is 7 hospitals? Could you tell me?
7 total. I knew you were going to ask that, so let me try to get this off the top. I forgot my list. So it's Intermountain Health. There are two hospitals in Phoenix, a children's hospital and then their sister company. They were not at the session. There were only 6. And the 7th was invited because they wanted to, they asked to participate in this. So the 6 of us were actually called and said, would you participate? So there are 2 of them. And then Dayton Children's. Intermountain's a big one, yes, in Salt Lake. Sorry, I can get you the full list, I'm so sorry. I'm trying to pull from who was sitting there, and I apologize.
All right, just.
They're big ones, so, yeah, they had actually a little contest before it started to find out what JPS actually stood for, so there wasn't anybody who got it right. So
I've got a question.
Sure.
The pilot sounds really, really neat. My question is, you mentioned how to get, the physician project was to gauge with and for instead of at.
Yeah.
How is the project not viewed by the doctors as just one more thing they have to do?
Yeah, so that's actually the challenge, right? So all of the modules are designed to be about 10 to 15 minutes long, and so with this first group that are our champions, our ask of them is literally a 10 to 15 minute time spent each week, and then using what they learned, that one technique, for example, with their patients. And then the rest of the project is designed around those physicians talking to other physicians, sort of like, I tried this and here's what happened and here's how it worked. And so it starts becoming more of a spark that leads to a flame that leads to a full fire. Okay. So, great. Yeah. So not a lot of ask on time for sure. Does that help?
Yes.
Okay.
Any other questions? Or,
So our kickoff is tomorrow, so we're very excited, and I apologize to those of you who are going to be in the quality meeting, because you're going to hear about it again. So if you have more questions, I'll be happy to answer them, and I'll bring back the hospitals that are participating.
You're going to ask the same question.
I know, I'll bring the list. I realized it when I sat down here, I thought, darn it, I forgot the list of the hospitals, so, yeah.
When I was practicing, I found that it was very difficult
You can turn the mic on, Dr.
to teach empathy to residents. That was something that you had to develop,
You
your
did.
parents taught you, et cetera, et cetera. You mentioned that the module the physicians are gonna be going through is empathy. How are you gonna measure it?
Some of those. Yeah, so first of all, when we teach empathy, you're right, it's very hard. In fact, for years, I have been asked, can you actually teach it?
Right.
And you can teach techniques that lead to it. For example, if you have a patient who is coming in and they're scared, one technique is to say, I know you must be really scared right now. And that shows empathy and compassion for
And you
that
have a right to be
patient.
scared.
Yeah. Well, hopefully not, right? But, you know, we've got this, and we're here for you. So there are little things that you can do that will help demonstrate that. And so that's the first thing, is it's just small tips and tricks that lead to being able to teach that. How we measure it is through our courtesy and respect questions, our explanation questions.
On the survey.
On the survey, we see reductions in complaints and grievances, because sometimes those come through that say things like, we just didn't feel like they cared. So about 10% of our comments last year in our patient experience surveys had the actual word feel in it. This is how I felt. This is how it made me feel. So we'll measure it that way, and we should see a shift in some of those metrics for the positive. We will see.
Okay.
Yeah. Yeah. So, and my favorite empathy story ever has to do with Wanda Peoples, and since we all know Wanda, I'll tell this, but it's old. It's before I knew her, actually, and I was a patient in one of her facilities, and I was having surgery, and they were walking me in, and then I have corrective vision, and I'm pretty much legally blind, and so I'm literally walking into the operating room, and I can't see anything. So they're guiding me, and the door's open, and the nurse says, I know it's really cold in here, but our hearts are warm, and we're going to do everything we can to keep you safe today. And I thought, man, if you don't talk about empathy being felt, I didn't know who she was. She could have done anything to me at that point. I'm like, here we go. But
The same goes for this room.
So, yeah, you're not kidding, it is cold in here, but our hearts are warm.
So, Laura,
Yes,
let me ask this question.
sure,
I'm going to give this example.
sure.
Tell me if this is an example of having empathy. A patient is at the hospital and he gets ready to go in for surgery. They do surgery. When he comes out of surgery, somewhere between the time of doing the surgery and completion, he flatlines and dies. But he was scheduled to get another surgery after this surgery. Okay. The doctor who was to perform the second surgery goes and taps the wife on the shoulder and says, you need to get us a private autopsy.
I got it.
So did that second doctor demonstrate empathy toward the family?
Not in my view.
Wasn't empathy for anybody.
No,
That happened just last week
wow.
at Baylor.
And say if it happened here,
Yeah,
For the record.
I'm really sorry about that. That's very painful.
Yeah, that's a tough situation.
That's very painful.
He sought the comfort of the lady. He said, you need to get a private autopsy.
Wow.
I'm sorry about that. That makes my heart hurt, actually.
Thank you.
So with that being said, that's awful, actually. We're only as good as the implementation of what we teach, though, right? So obviously, in that case, there needs to be some training that happens, and we would hope that would never happen here. And we are committed to doing everything that we can to help mitigate that risk, because we are humans, and that's part of being a human being is having those emotions and making sure that we manage those well. And so the second thing that we've really been driving here organizationally is a consistency in the behaviors that we're teaching. So things like empathy. So instead of saying that, say this. Instead of not touching the patient, touch the patient, briefly. Some of those are easy. And then how do you incorporate this within the hospital as a whole? Because empathy starts from the moment that somebody makes a phone call and the moment they walk through the door. And so that means that every single department in every area has to be doing what they can do, whether that's smiling, whether that's speaking to someone when you pass in the hallway, whether it's picking up trash, whether it is walking patients where they need to go, anything that we can do that helps to reduce that anxiety for our patients. If it's a physician and they're typing on a computer, or an MA who's doing a pre-visit questionnaire for the patient, you can't just look at the computer. You have to look at the patient in the eyes and really pay attention to what's going on. And so we teach those things all day long. So what our leaders are working on now is that trust but verify moment. How do we ensure that every patient, every day, every time that comes through our doors gets treated with the empathy and compassion that we want them to be treated with? And so we each play a role in that. And the consistency factor is something that is really challenging. And when we talk about something being hardwired, it means it happens at least 90% of the time. Well, we have 6,500 employees. And so to get that happening with, an average 3-day stay and, almost 100 interactions with that patient during that 1-day stay, that becomes very challenging. And so we are relentless in that pursuit. And that is probably, it's one of those things that I worry about all the time. So we are consistently keeping that in front of our leaders.
Any other questions for Laura? Outstanding job, I thought. This is, and this has been an ongoing conversation, and as Laura has taught me a number of times, this is not a, this is a journey more than a destination, and hardwiring is the hard part of it. So from a risk standpoint, we hope to partner with Laura, get this automated, work with your team, and track progress as we go.
So, let me ask a question.
Certainly.
Slide on the board. Will this roll out to employees throughout the hospital?
Well, my plan is to maybe not this exact slide. We have to kind of have the communications appropriate for the audience. But the ultimate objective of ERM is to have these be relevant to all JPS employees in some form or fashion. That's going, honestly, that'll take a little while to do. But yes, and of course we'll talk through kind of leadership in terms of how we want to do this. But this is, as I view it, risk is not an extra thing that you do. It's just a part of what you would normally do. And that's why when I talk in different forums about this isn't something, as Roger would say in some cases, this isn't extra to my job. This is just a part of what I do every day. And how can I make it a part of what you need to do every day, and that we capture that information, which is the hard part of risk management, and be able to operationalize and hardwire it. So it is, we're still on our journey. This is probably the second of probably 3 or 4 more steps to get to that point.
Yeah, the only reason I ask is because as it drifts down, that I think the key is the names you place where the risk owners are. If I'm not a staff member who's in this room, but I'm a staff member working down the hallway, I think it needs to identify that I'm the risk owner.
Yes.
At that spot.
That's a great
Yeah.
point.
Well, I think that, this is more or less our dashboard, but the employees down the line will then begin to see these strategies in place.
Right.
And probably that's where we would attach the ownership to.
Yeah,
Right.
and I know we're running, but a quick example is number 7 on priority question toolkit. So when we do rounding, on the senior leaders do rounding on Fridays, we ask the priority questions, but the staff leaders, the nursing leaders already know what their priority question are. They round on their own patients on a daily basis. And so this is more of a reinforcement of that and an acknowledgement of excellent staff work, because when we ask patients about how things have been communicated with you. And so that's a small example of how this strategy relates to every really nursing employee, that interacts with patients, as an example. Is that fair to say, Elaine?
Yeah, perfect.
I have one more comment for you, if I may. I can't remember where this survey came from, so I apologize. But the number one, I guess it wasn't a complaint, but call it a concern, by patients was that their physician did not spend enough time sitting down and talking to them. And what they viewed is physicians now come into a room, frequently don't even introduce themselves, sit down and will talk for maybe a couple of minutes, 3 minutes or 4, then they dive into the computer to start their entry stuff for the medical record, and then order tests. Instead of doing the basic, in my opinion, the basic things, which is you can take their pulse, you can look them in the eye, you can talk to them, and then at the end of that, you can order the tests and whatnot, and then explain to the patient what you're doing.
That's right.
So for me, the electronic medical record has a downside as well as upsides. And I think it will be a challenge to change some of that behavior.
It is.
And where will you measure that? I mean, that's still only
Yeah, that is still a question.
same survey?
That is, actually. It's how often did the physician spend enough time with you is the question. And we still measure that. We still look at that.
Okay.
And when we do observations with the physicians, that is, or even with, a nurse or an MA, and especially in a clinic environment, you see it a lot. In the rooms, you see it some, but our physicians that I have actually observed in the hospital don't use computers in the rooms for the most part. I think I've seen one do it, but in the clinics, it's a challenge. And so we work with them on just even things like making a personal connection with the patient as soon as they walk in the room will take you a long way too. Even if it's something as simple as, how about those Cowboys or, whatever, takes you a long way when it comes to relationship. Oh, what? The Raiders? Oh, are you an Oakland Raider fan?
Don't.
No.
There is not enough time with the right extra meetings to get into that.
Are they
Yeah.
still in Oakland?
They're
For now.
For now,
They're going to
yeah,
Vegas.
for now.
Well, Dr. Rhodes,
You
the
got to
other-
root for them when they're in Vegas?
Oh, Chuck said there's still a football team, Monday.
Yeah.
Well, Dr. Rover, the other thing is ERM is it's always changing, and these goals will always, the goal is to get one thing checked off,
That's right.
but then to put something else right behind it.
That's
So
right.
I think that those are things that we'll always follow up
Yeah.
on.
Absolutely.
I doubt very seriously that patient experience ever falls off the metrics and what we
Yeah.
measure.
Absolutely.
Yeah,
Ever.
how we measure.
Absolutely.
So, thank you all so
Thank
much.
you, Laura.
I'm
Thank you.
very- Yeah, certainly.
The way that you guys measure, is that standard everywhere, or is it different between ED and?
The survey?
on-
So there are different surveys, but we use the same surveys that CMS has driven, and so they're the same surveys that are used nationally. But there is one for the ED, there's one for the clinic visits, and then there's another one for our inpatient and another one for our operating room.
Because I still remember when I was using county hospital for healthcare.
You could,
And
I'm sorry,
When I was using county hospital for healthcare
Yes.
40-something years ago,
yes,
I personally don't care if the doctor spent time with me, because to me, everything's urgent. The only thing I want to hear is from the nurse telling me that you'll be okay, you're not going to die.
yeah,
And the doctor can spend 30 seconds with me, and I still appreciate the service they did at the hospital.
yeah.
So I'm not sure at what point do we need to start adjusting so that we don't throw the physician under the bus as we try to improve care also as well. Because the nursing staff has a lot to do with anchoring and, like you said,
Correct,
helping them, calm them, and set the expectation.
yeah,
And if they go in and out, it means you're fine. And because
Yeah.
no parents or no kid's gonna say that I'm fine until the doctor said, you're fine, I don't need to spend time with you. And I got kicked out the doctor's primary care physician, internal medicine a few times. Because I give you an example, right? Back in the old day, I was in Houston, and they was asking me to say, because I have a stomach problem. And he asked a few questions. He said, your dad in the military. Yes. Slow down. Don't swallow your food and keep up with him. Get out of here. I'm fine. And I still think he's the best doctor I ever can ever. Because he's telling me the truth. I need to slow down. So I just want to make sure that we're cautious about that also as well as we move things. Because when we're too strict, we may lose the physician also. But some of them, we always have exceptions to the rules.
Sure.
But for the most part, just moving things slowly so we don't lose people.
You're right, you're right. And just to clarify, that question is only on the clinic survey. It's not on our hospital or our ED survey. It is strictly in the clinic where that is very physician-driven. The rest of it, you're right. We tend to find that the experience itself is a lot driven on the inpatient side by the nursing team. You're right. And they're in there all the time, so they have the most impact. But you're absolutely right.
Thank you.
All
Thank you.
right, thank you, Laura,
Thank you.
appreciate it. If you're okay, we'll move
Ms. Irma, you ready?
into our compliance report.
You need another helper?
Yeah, always, yeah.
I'll have to tell everybody that Irma is the most patient person with me. Because I can tell Irma doesn't like her schedule to get messed up, and I am really good at messing it up. And I appreciate you very much for that.
Thank you.
And your patience.
Well, I'm gonna start on the first point on this slide. What we try to do in the compliance report is give you some trending things. Fortunately, I don't have to share with you any other indictments or settlements or anything of that nature, at least today, maybe next time. Actually, this is a positive comment. At the National Healthcare Compliance Conference, the same one that Frank and I spoke at, the OIG was there, the Inspector General was there. He's usually the keynote speaker, that's his deal. So he rolled out that this compliance program effectiveness guide is basically the OIG along with the professional association, HCCA, got together and went through all 7 elements of what the government considers to be an effective compliance program and have specific activities around each of those 7 as suggestions for providers and other healthcare providers as to these are the kinds of things that we would look to of saying that to establish effectiveness. So this is the first time they've gotten that level of detail and specificity, and so they were very proud of it. You could tell at the conference, and so they gave everyone a copy of it, and it's on their website and all of that. And so the reason why I'm bringing it up today is we're going to obviously look at this and see about incorporating some aspects of this into our next year's work plan, which you'll see here toward the end of the year. So, turn it over.
So to follow up on the key compliance activities that we're involved in right now, we have mentioned a couple of times that we are planning an OCR mock audit. We're actually in the middle of reviewing the responses that we got for the RFP that was submitted. We had 6 responses from vendors and the evaluation committee to decide who we'll be using for that engagement will be decided, and in the next couple of weeks we'll be meeting and making a determination and moving forward. And at some point we'll of course bring the results of that mock audit back to this committee. On the conflict of interest program, we rolled that out. Our conflict of interest, our annual disclosure of conflict of interest was rolled out in January, the first part of January. The statements were to be completed by March 31st. We had just over 1,000 total identified to complete the conflict of interest. That includes our providers and employees, if they're a manager or above, were required to complete the disclosure. The majority of those were completed. On the ones that we have gotten in, we have approximately 137 right now identified conflicts of interest or potential conflicts of interest that we're managing. We've divided those into categories as to how we think they might apply to the organization. They range from they have a family member that works here, all the way from a family member that works here to potentially having some interest in a company that we might do business with. And we manage those through the compliance department. And for the most part, there aren't any that are substantial, that are identified. This is a process that we go through every year. But if they're, in the event that there is a conflict of interest, an actual conflict of interest, and we work with general counsel and also take that to the compliance committee to make sure that we handle those appropriately. Also with the compliance activities, we have another RFP that was submitted for a coding and billing audit, a co-sourcing arrangement similar to what Michelle does with Chan for internal audit. On that, we submitted the RFP around the same time that we did the one for the privacy and security mock audit. We got 14 responses back, and so we're actually reviewing those right now, and that evaluation committee will be meeting within the next couple of weeks for us to determine if we want to move forward with that type of an arrangement and then what that'll look like. And then the last project that we wanted to talk about was actually yours, on the electronic consent.
Oh, yes, on electronic consent. So this is more of an enterprise-wide initiative. Melinda Costin is leading this, but essentially being able to have our consent, our general consent or consent to treat through Epic and automated through Epic. And also, it's not just automating it. The other key piece of it is ensuring that it's up to date with all of the requirements and so forth. And so there's a multidisciplinary group that's been meeting for the last several months to ensure that rollout goes smoothly. And so obviously the compliance touch point here is that consents are required obviously for consent to treat, and that as regulations around what should be in the consent change, we need to be able to update that in a very seamless manner, as opposed to, as you can imagine, if it was a paper consent, you'd have to pull all that paper back and then issue all the new ones, that type of thing. So I just wanted to mention that as a project.
And then also included in your packet are the routine compliance dashboard reports that we have. There is not any really thing that we wanted to point out significant about those, with the exception of there's a little bit of change in the actual reports. We have started separating out HIPAA from our usual reports that we manage, because they're so significant. We wanted to make sure that that we address those appropriately and then report on them appropriately. So we kind of line those up with the other compliance initiatives that we manage, or any complaints or any issues that we think that need to be managed. It's through our compliance management software system that we manage them, and so we're able to report on and dive deeper into some of the issues around HIPAA, since it's our most significant compliance-related report that we receive.
Any questions, Verma?
What's OCR stand for?
Office of Civil Rights. The Office of Civil Rights. So the Office of Civil Rights, last year, they sent out a notification to all hospitals that they plan to start an audit process around the HIPAA regulations, and they sent out also a guideline of what that might look like. And so for us to be prepared for that, we decided that we would have a mock audit by a consultant, similar to how the OCR would audit us if they came here. So all hospitals received the notification, but not all hospitals will be audited, but we don't know if we will or not.
Didn't you tell me, Irma, that those audits were beginning?
Yes, they're going to start at the end of this year.
Any other questions? All right, being none, we have a short closed session item that we will adjourn to, and then we will come back to you.
Thank you.
Mr. Chairman, I just want to mention one thing. I always like to take a chance. I should wait till all the employees are here. I had the pleasure this morning of attending the senior expo going on at Will Rogers. It's a huge deal put on for the county, tremendous turnout. I stopped in to see the JPS employees, or the volunteers employees, to say thank you. And I know previous chairman done the same thing. So I stopped in to tell them thank you. And as I was standing there waiting to talk to our employees, a young lady sitting to my left here as a volunteer at JPS said, "Sir, are you interested in our connection program?" And I said,
The connection
the
program.
connection program. And I said, you've got some, she said, "Oh, yeah, let me tell you about the program." And she went through the great spiel. And so I said, thank you very much. I really appreciate this. And I said, I want to tell you, I had the pleasure of working volunteer, and I'm kind of a volunteer at JPS. She goes, "Oh, you're a volunteer?" And we got all into talking about volunteers and all that. And I kind of said, as many of these board members know, yeah, I volunteer about 40 hours a week at JPS. But anyway, I just want you to know, and I did get around, we had and you know all the names, the ladies heads up our dental, we had dental there, we had a whole lot of employees, great representation on JPS. I jokingly said, by the way, she said, "And you volunteer, what area do you volunteer in?" I said, "Well, you know, I'm kind of involved with the board on some things and this other." So somebody came by and said, "Oh, Charlie," and they said, "Charlie's board chair, whatever, you know, don't make what the deal." And she goes, "Oh my gosh, don't tell Michelle Hayes." I said, and what I'm saying is, we just have so many employees out there doing it. And here they are on a Thursday. It must have been, well, I bet there's 4,000 people that went to parking place at Will Rogers for all the, you know, all the nonprofits are in there. And we had a major location. But I just, you know, again, it's just good, it's just a good feeling to feel JPS out doing what they do in the community. And yeah, a lot of the big health networks are in there and all that. But our people are doing a great job. And so I kid her, I said, "You know, you did a great job telling me about connection." I said, "And I probably need it." So anyway, I just want to pass that on to whoever up channel or whatever. The group did a great job.
Well, Chairman Powell, thank you, and thank you for all your extra hours. I know it's many, and Steve and Reverend, you guys have been there, so God bless you for that. Being no further business, we will adjourn at 1:10.